Democracy Now!, democracynow.org, The War and Peace Report. I'm Amy Goodman. Well, on Tuesday, President Obama signed the landmark health care reform bill into law. The move came after more than a year of debate in Congress and around the country about health care reform. Some of the strongest rhetoric in the debate came during the summer when Republicans began attacking components of the bill, saying they amounted to death panels. They were referring to provisions that would have required doctors to discuss end-of-life questions with terminally ill patients. Those provisions were taken out and were not part of the bill Obama signed yesterday. Well, today we turn to take a serious look at the aspect of medical care that often goes unnoticed. I'm talking about palliative care needed by people struggling with serious and sometimes terminal illnesses. I'm joined now by a pioneer in the field. Her name is Dr. Diane Meier. She's director of the Center to Advance Palliative Care and the Lillian and Benjamin Hertzberg Palliative Care Institute at Mount Sinai School of Medicine here in New York. She's received numerous awards, including a MacArthur Genius Grant. She's currently working with the Senate Committee on Health Education, Labor, and Pensions, known as HELP. Dr. Diane Meier joins us now from Washington, D.C. Welcome to Democracy Now!, Dr. Meier.
Thank you, Amy. It's wonderful to be here.
It's great to have you with us. And just in the interest of disclosure, I met Dr. Meier at Mount Sinai when my mother was struggling in the last weeks of her life. She died on October 5th. Today would have been her 80th birthday. And meeting Dr. Meier exposed my family to this remarkable field that we had known very little about. To start, Dr. Meier, tell us what palliative care is.
Palliative care is a medical and healthcare specialty that focuses on starting with the patient and their family and making every effort to reduce or eliminate suffering, whether it's from pain or depression or fatigue or worry, and helping patients and families get what they want from the healthcare system.
You deal with people at the end of their lives, but not always. Explain how that works.
Well, there's a common misconception that palliative care is the same as hospice. Hospice is a version of palliative care that is specifically for people at the very end of their life who are no longer going to benefit from curative or life-prolonging treatment. Palliative care, in contrast, is appropriate from the point of diagnosis of a serious illness, whether you're going to live with that illness for 10 years or 10 days. The goal of palliative care is to help people live as well as possible for as long as possible while they are coexisting with one or more chronic conditions. And in your mother's case, that was a recent and sudden diagnosis of cancer. In many of our patients' cases, it's things like heart failure or emphysema or dementia that people live with for years and years, but the burden of the illness is quite significant. And what our team tries to do is to lighten that burden and make those additional years worth having.
Dr. Meier, talk about the role of pain. Yes, in sickness, but also in wellness and in how people can cope and how it's treated by the medical profession today.
Well, we now know that pain is extremely debilitating and is a major risk factor and predictor for depression, for other illnesses, for social isolation, and actually for increased risk of death. So this notion that somehow pain is purifying or that it's noble to suffer with the pain or that it has a certain moral positive valence to grit your teeth and suffer through it is actually completely false. And we now know that untreated pain is really bad for your health, aside from the fact that it causes a great deal of suffering. Unfortunately, most physicians and nurses receive little or no training on the identification and appropriate treatment and safe treatment of pain. And as is true in many professions, when there's an area that you don't know much about and you're not very comfortable with, most people tend to assume it couldn't be that important. Because if it was really important, then they would have been taught how to deal with it and how to take care of patients with it. So we do see a lot of the health professions turning away from patients who are in pain or minimizing the importance of treating that pain, mostly because those health professionals actually don't know how to address it. And one of the things that the palliative care field is heavily focused on doing is improving the training of the next generation of doctors and nurses and other health professionals so that people in pain will have the expertise, have access to the expertise they need, because there are a number of ways to safely and effectively treat pain. It's just that our healthcare providers need to know how to do it.
For people who want to chime in here or ask a question or weigh in, you can email us at stories@democracynow.org. That's stories@democracynow.org. We're talking to Dr. Diane Meier, Director of the Center to Advance Palliative Care Institute at Mount Sinai School of Medicine here in New York. How do you deal with the pain? What exactly do you do? And what do you do differently than, well, conventional medicine?
Well, I think the most important thing that we do is recognize how important it is, and recognize that if a person is in pain, nothing else can really be accomplished. That is, they can't interact effectively with their families. They can't accomplish important goals to them. Very often they can't even get out of bed in the morning because the pain is draining all their strength and energy. So we begin by understanding that pain is basically a medical emergency, and it's very, very important to address it and work with the patient to get it under control. The second step is to ask the patient about the pain and to believe the patient about their pain. Believe it or not, many health professionals have been kind of trained to be suspicious of patients who describe pain and to worry that perhaps those patients are seeking substances they shouldn't have, or are really hidden addicts looking for access to opioid analgesics, and that the pain isn't real, rather than initially responding by trusting the patient and believing the patient's report of pain. So that's the second thing we do. We not only ask the patient about the pain, we ask them about its severity. We ask people to rate their pain on a scale of 0 to 10, with 0 being no pain and 10 being the worst imaginable pain. And we're then able to track the effectiveness of the things we do to try to treat the pain by asking the patient, what number is your pain at now? And explaining to the patient where we want that number to be. So, for example, if a patient tells me that their pain is at an 8 or a 9, we'll say that's completely unacceptable. We want to get that pain level at a 4 or below. So that's what we're going to work with you on, is adjusting the medication, getting the doses right, managing the side effects until we can get it to a 4 or below. And then we ask the patient, does that sound okay to you? That is, it's up to the patient what they want the target to be. And then we begin by administering medications, usually starting with very low doses and going up very gradually, because each patient is so different in the amount of medicine and the type of medicine they require to get their pain under control. And if someone is in severe pain, we sit at the bedside with the medication and don't leave until we have gotten that pain under control. One of the things that causes patients the most distress is this sense that even though they report pain, people aren't taking it seriously, people don't answer the call bell, doctors don't respond. So just by sitting there and saying, we are taking this really seriously and we're not going to leave your bedside until this symptom becomes bearable, that in and of itself so dramatically reduces the anxiety and the fear that it goes a long way towards making patients feel like they are in control and they can get the help they need.
I mean, that was what sort of shattered the paradigm for us, is that our mother had to be in so much pain before we could get help. And you coming in and saying, we have to shift this around. She shouldn't be experiencing pain from the beginning.
Mm-hmm. Right. And as you know very well, that she didn't get a lot of time after diagnosis, and that time was infinitely precious. And to have it chewed up by trying to suffer through and bear excruciating